This is Patrice Wendling reporting live from the American Heart Association Annual Scientific Sessions. I'm speaking with Dr. Christoph Kaiser, who just presented results from the Basket-Proof trial showing that there are no greater risks of cardiac death or MI when drug-eluting stents are placed in large vessels as opposed to bare metal stents. Doctor, does this lay to rest concerns about placing these stents in patients now in large vessels?
I think that this reduction in risk we found with the drug-eluting stents in large vessels does reassure us that we can place without any fear now drug-eluting stents in these patients.
This trial was conducted in Europe and in patients with a variety of coronary disease. Can this be extrapolated globally?
Absolutely. There's no sign that there is a different outcome in different countries. It can be extrapolated for the US and globally. Yeah.
And the benefits over a bare metal stent?
Well, the benefits over the bare metal stent is the one that drug-eluting stents were designed for. They reduce target vascular vascularization even in patients with large vessels.
And there were some concerns expressed about the power of the trial. Could you address those, please?
Yeah, we assumed much higher event rates than we actually had at the end. And if you take these event rates, you might argue that there's an underpowering of the trial. Given, however, the confidence intervals we have, we can basically rule out that there is still a late harm of drug-eluting stent in these large vessels. So I think the trial is quite reassuring.
Dr. Marco Valgemili made the following comment.
I think there are two main reasons why this study ended up to be a little bit underpowered. So first of all, I think the event rate, which was estimated, the 6% background event rate in the bare metal stent group and the 10.5% event rate in the drug-eluting stent arm has not been confirmed. So actually the event rate was in between 40 and 50% lower than what has been anticipated. And this, technically speaking, is of course leading to a lower than 20% type 2 error, which means basically that the study is underpowered. The second reason why this study is a little bit questionable is because the increase in events, which was expected to occur in the drug-eluting stent arm, is not real. This 75% relative risk increase has never been observed before in a properly powered prospective randomized control studies. So for these two reasons, my conclusion is that this study is very important because it's reassuring, but cannot be conclusive, as of course cannot rule out the possibility that there is a smaller than anticipated difference between drug-eluting stent and bare metal stent.
How should the practitioner in the community interpret these results?
I think it's a great question, and the interpretation, at least my implication for my practice, is that I can keep on implanting drug-eluting stent in patients with large vessel, which means 3.0 millimeter or greater, because actually I still have a TVR reduction if I do implant a DES versus a bare metal stent, and I don't have any late adverse clinical event. So I think if you have resources, DES stenting a large vessel makes sense because you spare TVR. If you are running short of resources, bare metal stent implantation is still reasonable because at the end of the day, the only difference is TVR.
This is Patrice Wendling, live from the American Heart Association Scientific Sessions 2010.